after 2 weeks you get your cataract surgery done, and post that cataract surgery after 2 weeks we will do the PRP. For pan-retinal photocoagulation, how is the slit lamp and the LIO? So Dr. Prerna, as per your opinion, which is like more precise, the slit lamp one or the LIO one regarding the spot size, the burn width apart? So you have seen cases laser with LIO as well as the slit lamp. So what is the difference you saw practically while examining the fundus?
Sir, I observed that with the slit lamp laser one, there are more precise laser one. Also, the spot size is also small as compared to PRP. Though it is time taking, but the more fields of constriction will be chance of field of constriction will be less in slit as compared to PRP, as the spot size is less. Though it is time taking, but it is more precise, I think.
Ask you, Dr. Nipun, Dr. Priyanka, that once you use on-slit lamp, you put the lens. So the patient cooperation, like patient cannot move the eyes. You can control, you can minimize the eye movements. Same thing we watch while doing the YAG laser. For uncooperative patient, it's always better to do YAG lens and especially multifocal or trifocal lenses. So is there any difference in that sense, like patient cooperative versus once you use lens versus you don't use the lens?
Yes, sir. When we use lens, the patient is they can't move the eyes, so we can do it more precisely in case of slit lamp. While doing PRP, patient can move their eyes. There is a high chance of hitting the macula. It's better to do slit lamp, I think.
I had this practical dilemma, and I this thing in patients with nystagmus, in patients with colobomas, in patients with dense cataract, and this slit lamp is much better, more precise than the LIO. In patients with paresis also.
Only disadvantage I personally feel it is in hazy media. LIO is better than slit lamp.
In hazy media and in cases of dense asteroid hyalosis with diabetic retinopathy. So what happens in dense asteroid hyalosis, we are not able to make out. So whether it is a severe NPDR or a PDR, so some doubt remains. So what we do is we do an FFA. If there is an NVE, we do an PRP with an indirect ophthalmoscope. It is better with. And in cases where there is a dense vitreous hemorrhage, we can always depress with LIO and do a laser. So in these scenarios, or in colobomas, or in these scenarios, LIO is much better. But in cases of the uncooperative patients, patients having 6 nerve paresis, patients having nystagmus, so to fixate the eye, slit lamp is much better. The spot size, because the spot size in the slit lamp is less 200. In LIO, it cannot go lesser than 460 micron. So in LIO, the irregular burns are there. Irregular widely spaced burns are there. So we need more precise burns in cases of PRP. So slit lamp is much better here. So these are some special situations.
One more thing I want to ask you, Dr. Nipun. Many times once we see, say in this Q4 cataract surgery also, some patients, the moment they enter the theater, they start making, complaint, pain. So you must have seen similar cases. Some parents must be very uncooperative. They, even after giving them, explaining them, they are not cooperative. So in those cases, what is your suggestion? In addition to counseling, in addition to explaining them, giving them some painkiller few hours or few minutes before PRP procedure, then also some of them they don't cooperate. And I have seen in cataract surgery the patients who are tobacco chewers or smokers, even you put block also, sometimes the block will not work, especially with tobacco addict people. So have you seen such cases in PRP also?
Yes, sir. Even in PRP, even in Barrage, I remember when just a few months back, Dr. Aishwarya was there. So we had one young girl with the Barrage, and she was very anxious and she was so afraid. Her brother was with her. We all counseled her that nothing will happen. She had an isolated lattice with hole, but that nothing will happen. But moment we tried to put the slit lamp lens, she was moving behind. She was so anxious. So we counseled her, we explained her the procedure thoroughly. And what I did is I sat on the slit lamp as a patient, and I told Dr. Shreya, my fellow, to put the PRP lens on me. Then when she put it on me, then she understood. Then she said, okay, sir is undergoing, the doctor is undergoing the procedure like very nicely. Then she understood, and then she cooperated nicely. So it is very important to counsel the patients. This was a little extreme measure, but
yeah, I think that's a very good tip you have shared, Dr. Nipun. And I have seen one case. She came for cataract surgery. She was 7-year-old. So my team told the people who did the biometry and OCD that she's very cooperative. Similar case I had done when Dr. Aishwarya came, case of traumatic cataract, and in this case was very cooperative.
This I remember, which was 6 years old, and he was very cooperative. Under topical anesthesia, he underwent cataract surgery.
So it's sometimes I wonder that people are 6-7-year-old, they are not complaining pain. And when I was doing this 7-year-old girl, so one person, 25-year-old female, was lying adjacent on that table, and I was supposed to do the phakic lens implantation. So she was shivering with pain, like she was trembling, like anything. So when this girl was talking, Joya Ansari's 7-year-old girl was talking to me while surgery, that what you want to become, so I want to become a doctor, something like that. So staff told that, okay, see, you can listen to her conversation. She's talking so confidently, and you are shivering and you are trembling with the pain. So sometimes the pain sessions, we have to just to explain them, and we to explain them what you have done, like demonstrating them by doing it. And that is very important, because in medical science, many textbooks we are not taught how to manage the extreme difficult case. So these are some of the tips which you can use in your practice to really convince the patient that this is not going to be painful. And while starting the first step, we should not lose the confidence of the patient by making sure that the hands should be gentle and every process should be less traumatic. Like even by putting drops, we should hold the patient head very gently, so that at any step we should not lose his or her confidence. Thank you.
You should keep toys from returning. You should keep some toys for return.
Yeah, that's a very important piece that Dr. Gupta sir told that we should keep some toys. And in the pediatric ophthalmology wing at LV Prasad and other hospitals, they are always dedicated room with lot of toys. So that attracts the children that this is going to be fun. So this is good suggestion, Dr. Gupta. Thank you.
And one more thing I learned from sir, that we should always talk with the patient regarding beyond his or her disease. That her brother was there in that case, so I told ki did he come for the Raksha Bandhan? So बोला कि नहीं भैया तो आया नहीं Raksha Bandhan पे. So the conversation went there कि अरे why didn't come? While in the conversation, her mind got distracted towards the Raksha Bandhan, that her brother did not come, and I just finished the Baraj lesson. So that distraction, that conversation, to connect with the patient, with mythology, with occupation. So this is a very good point, and yes.
That is a very good point, Dr. Nipun. Thank you so much for that. And by talking about non-ophthalmic things, will distract the patient, and that will engage her or him or her in most exciting activities. So whenever some elderly mother comes for cataract surgery, I always talk कि माताजी कितनी है, बेटे कितने हैं, बच्चे कितने हैं, शादी होगी, वो आई है नहीं आई, रोटी गर्म मिल रही नहीं मिल रही. These things, they help in relieving the anxiety, and that bring us for bring the patient for more exciting thing in the life. ये operation क्या है, boring thing. उनको लगता है कि बहुत स्ट्रेसफुल है, पता नहीं क्या होने वाला है. तो उसके बाद में जब वो सर्जरी करके या लेजर करके चले जाते हैं, तो लगता है कि खुदा बाहर निकला चुका, कुछ हुआ ही नहीं, ऐसा कुछ इतना डर रहे थे, ऐसा कुछ हुआ ही नहीं. And I think sir also have something to say, because sir has done many cases when block was there, as a small came surgery was there. So sir can also share the same experience.
We are doing surgery in usually critical dog or painful dog. We have not done without anesthesia and surgery. So, in uncomplicated patient, it is very essential for peripheral dog to you should learn peripheral dog.
Thank you.
In case of food case, in some places they used to give only nevenectin, not a combination of topical steroids. So is that okay, or we should give any? Is there another advantage of giving topical steroid plus antibiotic combination?
That's also fine. That's also fine. Yeah, that varies. Even the post where I was there in my fellowship, they used to give only topical NSAIDs and a lubricating. That's also fine. But when patient complains of little redness here and little practically little anxious patients and post laser redness has happened, that condition is transient actually. So we give a topical lotifred for at 3 days